Looks good. Okay, so I want to start us off with a statistic from endhomelessness.org. And this is based on a program in which different states participate and volunteers physically count the number of individuals who are homeless, either staying in a homeless shelter or on the streets. And it's one day out of the year they do a count. So in West Virginia, we have approximately 1,243 individuals who are homeless by the definition of staying in a homeless shelter or being unsheltered and identified by these volunteers. Of course, there are many more folks than that who have unstable housing, are at risk of losing their housing, or who are couch surfing or staying with relatives. Here's a breakdown from that same source, endhomelessness.org, kind of describing some trends in homelessness between 2007 and 2018, which is our most recent year for this particular chart here. And what we see is that a lot of individuals in West Virginia who experience homelessness are sheltered, and by large part are individuals as opposed to families. That's not the case in every state. We do have some policies that support housing for families that are at risk of homelessness. According to Charles Schwab and Company, around 59% of Americans are one paycheck away from homelessness in terms of not having sufficient money in savings to weather a financial crisis. Systemic factors that contribute to this are stagnant wages, in which increases in wages have not kept up with inflation, of course, inflation itself, and also the housing market. I know I'm from the Huntington area, I work at Marshall, and in our community, there is very limited affordable housing. So we have many individuals who have been approved for Section 8 HUD voucher who are not able to obtain housing because there are not enough houses on the market, even though they're already approved for that voucher. Some other, sorry, I'm trying to move my little toolbar here. Other factors related to homelessness among pregnant and parenting women with substance use disorder. According to ACOG, this is their committee opinion on healthcare for underserved women, which was initially written in 2010, but reaffirmed in 2021. Women and families represent the fastest growing segment of the homeless population, although at present, I believe single males are still the largest demographic who are unsheltered homeless in the United States. Around a third, 34% of the total homeless population is composed of families. And of those families, the vast majority, 84%, are headed by women. So single parent homes led by women. Domestic violence and sexual violence are the leading causes of homelessness for women and families, with 20 to 50% of all homeless women and children becoming homeless as a direct result of fleeing domestic violence. And in terms of our population, it's been estimated that around 30% of individuals who are chronically homeless have mental health conditions, and approximately 50% of chronically homeless individuals have substance use problems. So homelessness affects women, and in particular, our patients, pregnant and parenting women with substance use disorder, are overrepresented among homeless individuals. How does this affect the families that we work with? Well, according to a publication from the National Healthcare for Homeless Council in 2017, individuals who experience homelessness have higher rates of substance use disorders, poorer health, and higher mortality rates mortality from an opioid overdose than national average. Around 75% of patients experiencing homelessness with a past year substance use disorder also had a psychiatric comorbidity that was not substance related. In addition, individuals experiencing homelessness are more likely to have physical health problems, trauma, and have greater mortality from the same conditions that we treat folks who do have housing. Compared to individuals who are stably housed, patients who do not have housing are 9 times more likely to die from a drug overdose. And this is particularly pronounced among individuals who are leaving incarceration. With women in particular, so this is again from ACOG, the rate of unplanned unintended pregnancies is higher among homeless women than other American women. And homeless women are more likely to have access to inadequate contraception, so only contraception that has a high failure rate. They are much more likely to give birth early, to have a preterm delivery, to have a low birth weight infant, and to have a small for gestational age newborn. Even after adjusting for a lot of these overlapping risk factors that we see, homelessness itself carries its own share of the variance. And we control things like maternal age, number of previous pregnancies, and smoking cigarettes. Partially because homeless individuals tend to have more difficulty accessing routine health care. So compared to 24% of low-income individuals, around twice that, 57% of homeless individuals lack a regular source of health care. And that's in contrast with around 19% of the general population. Individuals who are either unsheltered or living in emergency shelter rather than their own stable housing tend to use what ACOG refers to as underground resources, such as participating in studies to enable them to receive health care. And one thing I'll note as a provider is that as we have a drug trial going on, and I have seen a significant increase in patients with high acuity who are being attracted to prenatal care because of the study. So I'm happy to see that, but it is really challenging some of the psychosocial needs that our newer patients have. So one thing that affects people in terms of their ability to access healthcare, whether they have stable housing or not, is whether they can physically access their healthcare. So this study by Holcomb et al. In 2021 found that the more complicated transportation was, and this was in an urban setting, not necessarily a rural area, but the more complicated the transportation was, the less likely it was that moms were able to get into prenatal care within the first trimester. So the overall findings of this study were that women without prenatal care were more likely to be non-white, to have higher rates of substance use, preterm birth, and longer length of time that the newborn was admitted to the hospital. And after adjusting for demographic features, there were higher rates of preterm birth in women who did not have prenatal care, even with controlling for other issues which we know are related to birth outcomes such as race. And women who did not receive prenatal care tended to live in areas that relied more on public transportation and had longer transit times with more bus stops. And as we know, in West Virginia, often our moms who are furthest from a prenatal clinic have no access to transportation. They don't even have public transportation most of the time. Okay, so this is a report on pregnancy-related mortality by race and ethnicity. This is a snapshot between 2016 and 2018. I want to show this just to emphasize the huge disparity in maternal and infant health outcomes for Black women in the United States compared to all races, but in particular compared to white women. I'm showing this for the kind of snapshot in time of 2016 to 2018, but as you'll see in the next slide here, outcomes are increasingly poor over time. So if you look here with the bars, the leftmost column is 2018 maternal mortality per 100,000 births. And the rightmost column are our numbers for 2021. And although maternal mortality increased in all three ethnic groups that were reported here, white, Black, and Hispanic, the numbers are astronomically larger for Black women in the United States. So this is a problem that is only increasing over time. Large part of that is due to access to care issues. So before I talk about how maternity care deserts are a factor for women here in West Virginia, I want to define what that means. So this is from the Kaiser Family Foundation. Maternity care desert is defined as an area that does not have a hospital or birth center, does not have an obstetric specialty provider, but does have women within childbearing age, ages 18 to 64 without health insurance. So if a location meets those three criteria, they would be considered a maternity care desert. In West Virginia, around 50% of our counties are considered maternity care deserts. The other 50% really range between these other three levels of access that we do have. And a lot of that is based on how many hospitals, how many obstetric specialists, and how many women have insurance in those areas. And I was referring to this earlier as I was putting this presentation together, and I was thinking that Cabell County may have actually changed access level because we now only have one delivery hospital in Huntington, and prior to this past fall, we had two independent ones. So we've actually maybe even changed to, I would say, moderate access, even in what's considered an urban area for West Virginia. It's important to note that for maternal health outcomes, as we saw in a previous slide, they're only increasing, maternal mortality that is, but this is especially a problem in rural areas, and rural women of color are at particular risk because of that intersectionality. Around 20% of people in the state who give birth, which equates to a little under 3,500 babies, are given birth to parents who live in maternity healthcare deserts. And there's a breakdown here by race. Of course, we know in West Virginia there's probably an odd interaction there because we do have large parts of the state that are so homogeneous. Sorry, I was stumbling today. So folks, it's just kind of natural that in more diverse populations are going to be in more of our urban areas that are less likely to be maternity care deserts. Barriers to obtaining prenatal care that even when it does exist within a community can health insurance. So we're fortunate in West Virginia in that we did receive ACA expansion. So women who are pregnant and up to 12 months postpartum are eligible for West Virginia Medicaid. And that's something that I'm grateful for in our state. However, I have noticed an increasing number of my patients who have relocated to Huntington for recovery or for employment, either their employment or a spouse's employment, who have had some difficulty with obtaining health insurance, and take that, and that's kind of a individual factor. Once we're able to work with them, we can get them enrolled in Medicaid pretty quickly, but they are uninsured prior to starting to work with our family navigators. Employment, particularly with the pregnant and parenting women who have substance use disorder, being able to obtain, if they are required to obtain separate prenatal care and, for example, medication assisted treatment, their employment may not permit them to attend as many appointments as are needed to give them a standard of care. Transportation, having childcare, having someone to watch older children while they go to their doctor's appointments. And I continue to see this really with a lot of my patients have older kids. So they're not talking about, putting a 1-year-old in a stroller and having them kind of hang out in the waiting area and then taking them into the appointment with you. But sometimes school-age children that they have to get off the bus, or older kids that, for example, if your child is suspended from school, then and you have to watch them, you can't leave them at home while you go to your doctor's appointment, but you also are not inclined to take them with you into your obstetric exam. Sometimes unsupported family or an unsupported spouse can be a barrier to obtaining adequate care, particularly if the patient is taking on a lot of these responsibilities for childcare. Having a fear of child protective services and other authorities. For example, if the person has a warrant in another state, that's much more likely to be the case in among women who have pregnant women with substance use disorder than kind of the general obstetric population. And also having had negative experiences with the healthcare system may kind of influence moms to delay in seeking prenatal care and not obtaining the prenatal care in the first trimester, which, as we saw previously, can be related to poor health outcomes. Okay, so a lot of these solutions are things that we can do as providers that come from ACOG guidelines. Before I go into these, though, I'll actually add that, one solution that we do have in West Virginia that's a solution to the lack of having adequate number, I should say, and access to obstetric care in West Virginia is that we have the perinatal partnership. The regional partnerships in which specialty obstetric providers can provide education, guidance, consultation to primary care providers who tend to be those who are attending births in more rural areas. That kind of information exchange really helps people to be able to have access to adequate care when their primary care physician or nurse is able to obtain guidance from specialty providers. These are all things that we can try to implement within our own practices. Identifying patients within the practice who may be homeless or at risk of becoming homeless by asking about their living conditions. Also, if folks are already known to have unstable housing or unreliable access to nutritious food, you can ask about nutrition. Pregnant women are already eligible to obtain some food assistance from the WIC program even before the baby arrives, and we really encourage our moms to take advantage of that. mental health issues, substance abuse, and domestic violence. You want to ask about that with all of your patients, not just those with substance use disorder, but particularly those who do or are you suspect have substance use disorder. It's recommended to provide health care for homeless women without bias, including preventive care and not withholding treatment based on concerns about lack of adherence. So I know that I have worked with folks, other providers who at times have not made recommendations or referrals because they feel that the patient is unlikely to follow through, but we do want to make it a standard that we are offering help and the same care to all of our patients and not making that decision for them by withholding that offer. Become familiar with and inform patients who are homeless or at risk of becoming homeless about appropriate community resources, including substance abuse programs, domestic violence services, and social services agencies. I know that there are certain resources in my community, Branches Domestic Violence Shelter, or I should say services. So they offer domestic violence shelter services, certainly, but they also offer advocacy, education, they have some support groups. And so there's a lot more to it than just the emergency shelter component. And that was something I learned on the job. So there are definitely ways that we can make ourselves more educated about what resources are available in the community so that we can help connect patients to them, even if it doesn't seem to us to be like an imminent or desperate need. Simplify medical regimens and address barriers, including transportation needs for follow-up healthcare visits. I think even just being mindful that not everyone's insurance pays for the same things, and that not everyone is able to pay cash for prescriptions or to pay the same amount out of pocket for prescriptions, and trying to case manage some of those. So the DFMV programs, I would say, are a great vehicle for having case management to be able to offer to at-risk patients by helping them with transportation and finding ways to pay for medication, for example. As a practice, advocating for initiatives to address homelessness, such as increased funding for housing, case management services, substance abuse treatment, mental health services, domestic violence programs, and primary and preventive care for homeless individuals. I did see that the West Virginia legislature had just passed this spring a bill to, and it was signed into law to investigate homelessness in West Virginia. That is something that had been, appeared to me, I don't want to misspeak, but it, from my vantage point, seemed to be put on the back burner for maybe a couple administrations, and the state is going to pick that up, so that makes me very happy. Providers can volunteer to provide healthcare services at homeless shelters and other facilities that serve homeless individuals. And increasing access to long-acting reversible contraceptives. Recall earlier that a lot of women who are living in shelters or are unsheltered don't necessarily have access to contraception that is the most effective, and the voluntary long-acting reversible contraception is a great way to have an effective form of contraceptive that it does not rely on you being able to get refills and take a pill at the same time every day. All right, so I'm going to quickly check on the chat before going on to the case study and see if I have any questions before I get in there.
Nothing in the chat as of now, Jennifer.
Looks good. All right. So this is a recent patient. Ms. A is a 35-year-old Caucasian woman who entered medication-assisted treatment at 20 weeks pregnant. She had just transitioned to an apartment from sober living and utilized wages to pay up her rent 6 months in advance. She was on conditional release for drug-related charges. She admitted to her PO that she had a relapse. She actually didn't fail any drug screens, but as part of her recovery process was being more honest and forthright, admitted her relapse, and then she was remanded back to regional jail, still pregnant, and is at risk of losing her apartment. And she, at this point in her life, has worked very hard for the level of stability that she had prior to being remanded back to jail. I recall her telling me that with one of her pregnancies, and she does not have custody of her older children, but one of her pregnancies, she was sleeping on the riverbank and just trying to stay alive during that pregnancy. So she's worked really hard to get where she is. And even with having the foresight to pay for her rent, she's still at risk of losing her apartment. Aside from her relapse, which was triggered by psychiatric issues, mental health issues that have since stabilized, she was doing well in the program prior to her incarceration. So she was coming to group every week. She was talking to her peer recovery coach, and participating very well in therapy. So this is what we've tried to do for her. So we're fortunate that kind of due to certain circumstances, she's continued to be able to receive MAT while in jail. That's not necessarily a typical thing that we could rely on for all of our patients, but this was something that has been able to happen for her, likely due to her pregnancy. Our peer recovery coach has maintained contact with her during her period of incarceration to check on her and to provide encouragement. Our family navigator, which is kind of a care coordination position, if we have other folks on the call that participate in the mom model program through Drug-Free Moms and Babies. She's like a care coordinator, essentially. She's scheduled a professional visit to the jail. So she was able to have a contact visit to help her fill out housing applications while she was still incarcerated. With her permission, she identified the family member who is going to be her support person. We're anticipating she's going to have CPS involvement with this baby, and so she has already chosen ahead of time who she would like to be her support person, and has signed releases for us to be able to have contact with this person. And we've been able to obtain some infant essentials that are necessary to that family member to help to enable them to support her by preparing them. And the plan is that she will resume group after her release. And we're still working on her housing situation. I can share a little bit more about our local area. In the greater Huntington area, we have the Huntington Housing Authority, which oversees our subsidized housing, so that patients are able to, in some cases, live in public housing rent-free if they meet certain criteria or have very low requirements for what they must pay, but they're also income-based. So some of the apartments, if the person is employed or has a source of income, they may pay what is a very inexpensive, reasonable fee, but they're still paying something toward their housing. We also participate in the HUD Section 8 waiver program, where folks can get a voucher to essentially pay for an apartment, pay full price essentially of the rent for an apartment, but the owner of the housing has to agree to accept the Section 8 vouchers. And we have a limited supply of those in our community right now. Right now we have I've heard this number. I don't know if it's a literal number because I haven't seen a specific source, or if it's kind of metaphorically what people are saying and then repeating it. But around 100 people who have the vouchers, so they have been approved to spend this money, and the money is there for them, and they are not able to find an apartment that would accept the voucher. Again, because in Huntington, we really don't have an adequate supply of housing for that is in habitable condition, that's in the price range for folks that are either receiving assistance or working lower income jobs. So what we do is a scattershot approach. We ask people to apply directly to the low income housing apartments. A lot of them maintain their own individual wait list. So you call around and try to get on the apartment's wait list, at the same time applying for the Section 8 voucher program, because it does take a long time. So it's kind of a two-step process. Maybe someone will live in a less desirable subsidized housing apartment until they actually obtain the voucher, or they are, if they've been employed, they may be able to save up some income during the time that they've been living in subsidized housing, and then move into the apartment that they use wages for after some time of being able to put back sufficient money for a deposit. So we try multiple methods. One thing that stands out to me about what we've been able to do to assist this patient while she's been incarcerated is that we have a fair amount of moms over the years that have Huntington has been kind of the closest place for them to obtain healthcare. Their actual residence is in one of the maternity care deserts, and it's harder to find housing for them, because even if they're able to get approved for a voucher, the supply of low-income housing or affordable housing is even lower in a lot of those communities. You literally just have to know someone who would be willing to rent to you. And so even though we have a lot of resources in our area, it's still a challenge, but I'm aware of how much more of a challenge it is in other parts of West Virginia. And how I see this affecting a lot of my patients. So of course, we've talked about how that can increase risk for birth, poorer birth outcomes, but also exacerbation of mental health issues. But it affects our patients in very practical ways as well. So for example, CPS is not likely going to discharge if you receive a report because you test positive for a substance at delivery. CPS is unlikely to discharge the baby home to you, or let the baby be discharged home to you if you don't have stable housing to take them with you. So that's always the first issue that we try to address with patients as they're coming into treatment. All right. So at this point, I'll share my contact information as well. My email address is mills126@marshall.edu. Phone number is 691-6414. And as I've been referring to our DFMD program at Marshall Health, it's Healthy Connections. So you can also check that out at healthyconnectionswv.org. But at this point, I would really like to encourage any questions, comments, or if I left anything out for my patient that you think would be a great resource, please unmute yourself and let me know.
Hey, Jen, we don't have anything in the chat, but maybe can you stop the share so we can see the Hollywood Squares? There we go.
Each other a little better.
Yeah. So Jen, I'll throw out a question as a non-provider by any means. But just, you went through a lot of information, just like of the things that you could potentially talk to your patient about, right? Just all the different things, and it's all changes, depending on who they are, right? And what's going on in their lives. Do you have the time to really have those thoughtful conversations about all those different things? Because, when I go to my PCP, they don't want to talk to me for more than like 10 minutes, and I don't have the issues that are going on, fortunately, that these patients do. So I'm curious about that.
I think that's really where the perinatal partnership and the DFMB programs come into play, because our providers don't have that kind of time either. And as a therapist, oftentimes those things will come up as stressors, but we also have a lot of ground to cover typically in 45 to 60 minutes. So how we make that work, the MARC program, so if I'm referring to we and my patients, for the context of pregnant and postpartum women, our outpatient medication assisted treatment program is the MARC program, and our moms receive their prenatal care in the same health system where we provide their MAT, and we go to them. So we have our group meetings are on the OBGYN floor. We also try to work with their provider to make sure that patients are going to their, we check their chart to make sure they're actually, getting their ultrasounds done, going to all of their appointments. And what we'll do if something comes up during a medical visit or during therapy, is a warm handoff to the family navigator or care coordinator, and a lot of the programs is how they're referred. And what we do, which I believe is similar, I don't want to speak for Laura, but I believe they have a similar setup. We have our peer recovery coach and our family navigator come to the weekly group therapy, and they actually sit in on group, so that our patients become really comfortable. And actually this whole thing behind me, that's a whole stack of stuff. We were able to get some grant funding for infant essentials. So our family navigator is able to act really quickly and nimbly when they find out there is a need to go ahead and get that filled. That helps to keep the family in treatment and keep them motivated. I think from what I've seen, the more that people are really struggling with some of these psychosocial stressors, it inhibits their ability to really focus on their recovery and to stay sober. You tend to see a lot of reoccurrence of substance use when their stress is unmanageable and they don't have like a clear pathway of how they're going to get these things met. And often these a lot of support exists in the community. Once you're able to cobble everything together between temporary assistance for needy families and SNAP benefits and WIC and some of our community pantries, they can do it, but it's about showing them how they can do it. And so the family navigators can kind of take them by the hand and take them wherever they need to be. So that's usually who is having those kind of conversations, but they do get flagged by the providers. I'm curious for other folks that are on the call. I noticed when I was looking at the homelessness interactive map, in Cabell County, our incidence of unsheltered homelessness was about twice the state average. So I think we were like 14 for every 10,000 or 100,000. I'm not sure. We were double. So I'm curious, folks that are not in Huntington, what do your kind of homeless outreach services look like? We have our navigators, but if we didn't have kind of the benefit of kind of all the services that we have in our community for them to access. I wouldn't know. Yeah, not being sure. And that's the thing. A lot of the information that I have and that my navigators have is based on just years of helping patients problem solve. So when there's a new issue that comes up, then we get really in-depth familiar with those services. And then, you know, occasionally something unanticipated comes up. But housing has been something that we've really learned to be very assertive at tackling. And also, thank you, Kathy. Housing is something we've become really assertive with attacking, but then also the access to care issues. So as I was reviewing the slide about barriers, you know, transportation, employment, unsupportive spouse, as I was reading all, it's like, I have one patient, but it's like, she has all of them. So it can be really hard to problem solve. And which is also another reason for, I think, having a very non-judgmental and kind of systems focused view of some of these issues, as opposed to kind of blaming the individual person. Yeah, Jamie's saying that there's not many resources for homelessness. I know that for us, when we've had someone prior to the pandemic and the expansion of telehealth, we had people drive 90 minutes, 2 hours sometimes to get to Huntington for sometimes just their MAT, but also if they were high risk, this was the only place that they could access high risk obstetric services. And so when we would try to help them come up with a plan for housing in their actual community, in their area, it was really challenging to find something unless just word of mouth, they happen to know someone who was willing to rent and they had some kind of income such as TANF or SSI.
Thanks, Hannah, for the chat. Yeah, just need to be more aware of the services and see what's out there. Good. Any other comments or questions? Jennifer, thank you so much for putting that together today and going through the case and the presentation. Much appreciated.
Yeah, and for those that are coming up with like kind of questions about getting their own network of resources together, if you have any questions about how we did certain things or whatever, just please reach out.
Great.
Bye, everybody.
Yeah. So we can go ahead and get ready to end this session. The one thing I did want to share, one quick thing with you for in regards to ECHO, we do a participant survey twice a year. And so this slide here, yeah, I did not make this slide. I can't take credit for it. This is one of my colleagues. But it is to basically get a better understanding of how you guys are feeling, how the sessions are going, what you would like to see in the future, you know, because we're constantly trying to change and improve. So you'll get another email about this with the QR code and an actual link. But if you want to take it now, it's only about 5 to 10 minutes. And you can scan that code that are by those huge ears there. And yeah, it's going to be up for 2 weeks. So by no means do you have to do it right now. But I just wanted to share that with you. Anything you can provide, you know, be critical because we want to know. So we appreciate that, but more, you'll get a separate email from our group to the entire group with that information. All right. Yeah, thanks for coming again to the rescheduled date. We're back on track in April. April 10th is our next session at noon. More info to come on that as well. And thanks again, everybody, for showing up. And Jen, thanks again for your time and willingness to do both today. All right. Take care.